Chapter 9. Anxiolytic and hypnotic drugs. Overview. Disorders involving anxiety are among the most common mental disorders. Anxiety is an unpleasant state of tension, apprehension, or uneasiness. A fear that arises from either a known or an unknown source. The physical symptoms of severe anxiety are similar to those of fear, such as tachycardia, sweating, trembling, and palpitations, and involve sympathetic activation. Episodes of mild anxiety are common life experiences and do not warrant treatment. However, severe, chronic, debilitating anxiety may be treated with anti-anxiety drugs, sometimes called anxiolytics, and/or some form of psychotherapy. Because many anti-anxiety drugs also cause some sedation, they may be used clinically as both anxiolytic and hypnotic, sleep-inducing, agents. Figure 9.1 summarizes the anxiolytic and hypnotic agents. Some antidepressants are also indicated for certain anxiety disorders, however, they are discussed with other antidepressants, see Chapter 10. 2. Benzodiazepines. Benzodiazepines are widely used anxiolytic drugs. They have largely replaced barbiturates and meprobamate in the treatment of anxiety and insomnia, because benzodiazepines are generally considered to be safer and more effective, Figure 9.2. Though benzodiazepines are commonly used, they are not necessarily the best choice for anxiety or insomnia. Certain antidepressants with anxiolytic action, such as the selective serotonin reuptake inhibitors, are preferred in many cases, and non-benzodiazepine hypnotics and antihistamines may be preferable for insomnia. A. Mechanism of action. The targets for benzodiazepine actions are the aminobutyric acid, GABA, receptors. Note, GABA is the major inhibitory neurotransmitter in the central nervous system, CNS. The GABA receptors are composed of a combination of 5 alpha, beta, and gamma subunits that span the postsynaptic membrane, Figure 9.3. For each subunit, many subtypes exist. For example, there are 6 subtypes of the alpha subunit. Binding of GABA to its receptor triggers an opening of the central ion channel, allowing chloride through the pore, Figure 9.3. The influx of chloride ions causes hyperpolarization of the neuron and decreases neurotransmission by inhibiting the formation of action potentials. Benzodiazepines modulate GABA effects by binding to a specific, high-affinity site, distinct from the GABA binding site, located at the interface of the alpha subunit and the gamma subunit on the GABA receptor, Figure 9.3. Note, these binding sites are sometimes labeled benzodiazepine, BZ, receptors. Common BZ receptor subtypes in the CNS are designated as BZ1 or BZ2 depending on whether the binding site includes an alpha-1 or alpha-2 subunit, respectively. Benzodiazepines increase the frequency of channel openings produced by GABA. Note, binding of a benzodiazepine to its receptor site increases the affinity of GABA for the GABA binding site, and vice versa. The clinical effects of the various benzodiazepines correlate well with the binding affinity of each drug for the GABA receptor chloride ion channel complex. B actions. All benzodiazepines exhibit the following actions to some extent. 1. Reduction of anxiety. At low doses, the benzodiazepines are anxiolytic. They are thought to reduce anxiety by selectively enhancing GABAergic transmission in neurons having the alpha-2 subunit in their GABA receptors, thereby inhibiting neuronal circuits in the limbic system of the brain. 2. Sedative/hypnotic. All benzodiazepines have sedative and calming properties, and some can produce hypnosis, artificially produced sleep, at higher doses. The hypnotic effects are mediated by the alpha-1 GABA receptors. 3. Anterograde amnesia. Temporary impairment of memory with use of the benzodiazepines is also mediated by the alpha-1 GABA receptors. The ability to learn and form new memories is also impaired. 4. Anticonvulsant. Several benzodiazepines have anticonvulsant activity. This effect is partially, although not completely, mediated by alpha-1 GABA receptors. 5. Muscle relaxant. At high doses, the benzodiazepines relax the spasticity of skeletal muscle, probably by increasing presynaptic inhibition in the spinal cord, where the alpha-2 GABA receptors are largely located. Baclofen is a muscle relaxant that is believed to affect GABA receptors at the level of the spinal cord. Therapeutic uses. The individual benzodiazepines show small differences in their relative anxiolytic, anticonvulsant, and sedative properties. However, the duration of action varies widely among this group, and pharmacokinetic considerations are often important in choosing one benzodiazepine over another. 1. Anxiety disorders. Benzodiazepines are effective for the treatment of the anxiety symptoms secondary to panic disorder, generalized anxiety disorder, GAD, social anxiety disorder, performance anxiety, post-traumatic stress disorder, obsessive-compulsive disorder, and extreme anxiety associated with phobias, such as fear of flying. The benzodiazepines are also useful in treating anxiety related to depression and schizophrenia. These drugs should be reserved for severe anxiety only and not used to manage the stress of everyday life. Because of their addiction potential, they should only be used for short periods of time. The longer-acting agents, such as clonazepam, clonazepam, lorazepam, lorazepam, and diazepam, are often preferred in those patients with anxiety that may require prolonged treatment. The anti-anxiety effects of the benzodiazepines are less subject to tolerance than the sedative and hypnotic effects. Note: tolerance, that is, decreased responsiveness to repeated doses of the drug, occurs when used for more than 1 to 2 weeks. Tolerance is associated with a decrease in GABA receptor density. Cross-tolerance exists between the benzodiazepines and ethanol. For panic disorders, alprazolam is effective for short and long-term treatment, although it may cause withdrawal reactions in about 30% of patients. 2. Sleep disorders. A few of the benzodiazepines are useful as hypnotic agents. These agents decrease the latency to sleep onset and increase stage 2 of non-rapid eye movement, REM, sleep. Both REM sleep and slow-wave sleep are decreased. In the treatment of insomnia, it is important to balance the sedative effect needed at bedtime with the residual sedation, hangover, upon awakening. Commonly prescribed benzodiazepines for sleep disorders include intermediate-acting temazepam, tmazepam, and short-acting triazolam, triazolam. Long-acting flurazepam, flurazepam, is rarely used, due to its extended half-life, which may result in excessive daytime sedation and accumulation of the drug, especially in the elderly. Astazolam, astazolam, and quazepam, quizepam, are considered intermediate and long-acting agents, respectively. Temazepam. This drug is useful in patients who experience frequent awakening. However, because the peak sedative effect occurs 1 to 3 hours after an oral dose, it should be given 1 to 2 hours before bedtime. Triazolam. Whereas temazepam is useful for insomnia caused by the inability to stay asleep, short-acting triazolam is effective in treating individuals who have difficulty in going to sleep. Tolerance frequently develops within a few days, and withdrawal of the drug often results in rebound insomnia. Therefore, this drug is not a preferred agent, and it is best used intermittently. In general, hypnotics should be given for only a limited time, usually less than 2 to 4 weeks. 3. Amnesia. The shorter-acting agents are often employed as pre-medication for anxiety-provoking and unpleasant procedures, such as endoscopy, dental procedures, and angioplasty. They cause a form of conscious sedation, allowing the person to be receptive to instructions during these procedures. Midazolam, is a benzodiazepine used to facilitate amnesia while causing sedation prior to anesthesia. 4. Seizures. Clonazepam is occasionally used as an adjunctive therapy for certain types of seizures, whereas lorazepam and diazepam are the drugs of choice in terminating status epilepticus, see Chapter 12.